Hi, my name is Shannon Moore. I am a level 2 nursing student at Weatherford College, and I am here to talk to you today about the head-to-toe assessment. Here to help me today is my sister Valerie, and she's going to be our model for today. The head-to-toe assessment is exactly what it sounds like. It's an assessment from your head to your toes, and it is what guides the patient care plan. A good way to remember the nursing process, which is what the head-to-toe assessment is part of, is with an acronym known as ADPI. So ADPI stands for Assessment, Diagnosis, Plan, Implement, and Evaluate. What we're doing today, the head-to-toe assessment, is the first step of the nursing process. A couple of good resources to use are Crash Course, registerednursing.org, registerednursern.com, and nursenicole.com. All of these resources have videos on YouTube that are very helpful. With Crash Course specifically, while it's not nursing specific, it does help with the anatomy and physiology and learning more about the systems to help you as you go through the head-to-toe assessment. All right, with the head-to-toe assessment, the place that we're going to start is at the head, or more importantly, the hair. When you start with the inspection of the hair, you're going to want to look at, is it brittle, is it strong, is it dyed, is it not, do they have hair? We're going to look at the scalp to see if it's symmetrical, if there's bumps, lumps, lacerations, or other things going on. And we're also going to check and make sure that there's not other things that may be happening on the head like lice. And next we're going to move on to the ears. With the ears, one key note would be that with adults, you're going to want to grab the top part of the lobe and push it up and back to look at the ear, while with kids, you will grab the lower part of the lobe or even middle part of the lobe and push down and back. This is just because of the way the ear canals line up. But other than that, you'll want to inspect for redness, tenderness, obstructions, or excessive wax or anything else with the ears that may be going on. The next thing you're going to want to assess for would be what's called the whisper test. This is where before you go around the patient, you're just going to tell them that you're going to say a word and you want them to repeat it back to you. You then go behind the patient, whisper a word, and have them repeat it back to you. You'll want to do this on each side to make sure that you're testing each ear. And next, we will move on to the eyes. So with the eyes, there's a couple of acronyms that are key to whenever you do the assessment for the eyes. One of them is known as PERLA, which is Pupils Equal Round Reactive Light Accommodation. This is where you get your handy dandy pen light and you'll turn it on, and what I like to do is I like to stand face to face with my patient and have them look at my ears. I then shine the light on one side of their face to just one eye. While I'm doing this, I'm looking at their pupils to make sure that they both respond at the same time. I then will move that light and I will go to the other side and have them look at my other ear, and we'll do it again. Sometimes when I do this, I will give a break between the two so that my patient doesn't become disoriented or confused. As we move on, we're going to use another acronym, and this one is EOMS, which is Equal Ocular Movements. This is where we take the pen light again, but we don't necessarily have it on, and we have the patient look at the pen light. And as we do it, we're going to move it left, right, up, and down. And sometimes if they looked away, I'll also go diagonal. And then finally, I warn them before I do this because it can sometimes scare people, you bring it closer to them to see if their eyes move more midline. Be sure to warn your patients with this because this can come off frightening at first if they don't know that you're going to come close to them. And next, we're moving on to the nose. The next is with the nose, and the nose with the sinuses. So with the sinuses, you're going to use the side part of your thumb, and you're going to press down on their cheekbones, around the bridge of their nose, and sometimes even around the bridge of their eyes. Here is where you can have increased sinus pressure as a result of allergies, and so if your patient is feeling discomfort or pain as a result of that, be sure to document that and ask them if they have regular allergies, and if so, what their normal allergy regimen is. You're then going to take the pen light, you're going to tilt their chin back, and you're going to shine the pen light up their nose to make sure that the septum deviates midline and that there isn't increased swelling or lacerations in their nose, and that the mucosa is moist and pink. Next is the mouth. With this one, I would like to encourage you to demonstrate what you're going to ask your patient to do before you tell them to do it, because sometimes it can be hard to articulate that. So for instance, when you tell them to go ah. And you're going to take your pen light again and you're going to shine inside their mouth and you're going to look for anything like dentures, pus. You're going to want to see if their mucosa is pink and moist, which is what we want. But you're going to check to see any crowns, fillings, etc. You're also going to want to inspect the uvula and make sure that when they go ah, that the uvula raises midline. After that, you're going to ask them to stick out their tongue and go left to the right. Next is the cheek and neck, where we're going to take the back of our hand and place it lightly against their cheek. You might want to warn your patient before you do this. You're then going to ask them to shake their head as if they were saying no and meet a little bit of resistance doing so. Next, you're going to move on and you're going to check their range of motion with their neck, and you're going to have them take their head and go side to side as if they were putting their cheek to their shoulder. You're going to also ask them to put their chin to their chest and back up again. This is a good way to test the full range of motion of the neck. As you continue to move down, you're going to check the trachea, make sure that it's midline and that their swallowing reflex is intact. This is very easily assessed by just asking them to swallow and observing their Adam's apple move. You're going to then continue and check the pulses on each side. Do it separately, not at the same time. And you're also going to listen to make sure to check for bruit, which I have been told sounds like a whooshing. As we move down to the chest, I'm going to talk a little bit about vital signs. The first vital sign that you're going to take is the blood pressure. With the blood pressure, you want to make sure that you get an appropriate sized blood pressure cuff and that it's not in the crevice of the arm, and that you are able to hold the squeeze mechanism and the stethoscope with control and ease. Next is the heart rate. Oftentimes with the heart rate, we take a radial pulse, but you can also take the pulse in various other ways. But it's just that radial is typically the most comfortable for our patients, and so that's where we get it. The way you find the radial pulse is if you're looking at a hand with the thumb closest to you, you're going to follow along the line of the thumb and go down to where there's a bone point, and it will be a soft, palatable area. There you'll find your pulse and take it for a whole minute. Next, you move on to respirations. With respirations, you're just going to need a clock with the second hand, and you're going to count the respirations of your patient for a full minute. With this, you might not want to tell them that you're taking their respirations, but instead act as if you're taking their pulse again. This is because people unconsciously, when you tell them that you're taking their respirations, will change their breathing pattern. It's not that they mean to, it's just the moment you think that you're breathing, you change your breathing. After that, you're going to take their temperature. There's a variety of ways that you can take a temperature. Oftentimes in the hospital, we take an oral temperature. And lastly, you do a pain assessment. With a pain assessment, we use an abbreviation known as COLDSPA. COLDSPA stands for Character, Onset, Location, Duration, Severity, Pattern, and Associated Factors. With this, you want to be sure to ask the patient what makes it better, what makes it worse, when does it happen, how does it happen, and other things like that. A scale we oftentimes use to judge the severity of pain is a scale of 1 to 10. If they tell you that their pain is anything more than a 0, you want to be sure to do something for their pain. You don't want to assess pain and hear that there is pain without doing something for pain. Next, we'll move on to heart sounds. With heart sounds, there's a good way to remember it known as All People Enjoy Time magazine. A is for aortic, P is for pulmonic. Both of these are found at the second intercostal, one on the left, one on the right. E is for Erb's point, it is found at the third intercostal. T is for tricuspid, it's found at the fourth intercostal, and M is for mitral, found at the fifth intercostal. You're next going to listen to your apical point for a full minute. The reason why you're going to listen to this for a full minute is that heart rate that we got earlier, we're going to compare to the apical point. And if there's a drastic difference, then we may want to assess further on their perfusion and how well they are getting oxygenated blood. Next, you're going to move on to your lung sounds, and we're going to listen to lung sounds on the back. Keep in mind which side and which lobe you're listening to, as these can be key factors in the assessment. A good way to remember which lobe you're on is to remember that the left side, because that's where the heart's located, only has 2 lobes, while the right side has 3. As you move down the back, you're going to move in almost an hourglass form to listen to your lung sounds. When you get down to the bottom, when you're trying to listen to the lower lobe of the right side, be sure that you might want to go more under the arm to hear a better sound of that lobe. When you move onto the abdomen, let your patient know that you may have to move their shirt or gown to see it, and be sure to look for lumps, laceration, bruises, or asymmetry. Remember that when we move to the abdomen, we change how we assess. So we no longer look, palpate, percuss, listen. We now look, listen, palpate, percuss. The way you listen to the abdomen is you divide it into 4 quadrants, with the umbilicus as kind of the middle point of all the quadrants. I prefer to start in the upper right lobe and move in a clockwise fashion. When you listen, if you're not hearing vowel sounds, be sure to either move your scope and try again, or to listen for a full minute. Sometimes things like tissue or fluid can block the sound, and so moving it and trying to find a different place to listen to can be very important. As you move on, you're going to palpate. As you palpate, you're going to press down 2 or 3 centimeters around the different quadrants. I like to do 2 different places in each quadrant and continue on with my clockwise position. You're then going to percuss. Percuss is to press down 1 to 1.5 inches down and bring that up. Be sure to ask the patient about pain, discomfort, constipation, or any other type of GI distress that may be going on recently. This may include conversations about their poop and how regular it is. As you move on, you're going to move to the urinary. You're going to look for distension, for bruising, for pain. You're going to percuss and palpate there as well. And you're going to ask them about their urinary continence and how often they urinate and what that urine looks, smells, or how easily it's passed. Next, you're going to move on to the legs. As you look at the legs, you're going to want to check for edema, bruising, lacerations, or other things that may be going on. You're going to want to check for a pitting edema, which is done by pressing the thumb firmly onto the shin bone and seeing if the fluid is displaced and stays that way. Depending on how long the indentation stays, depends on whether it's a +1, +2, +3, or more pitting edema. As you continue, you're also going to check for range of motion and strength. You're going to do this by asking the patient to bring their legs up with resistance, down with resistance, forward, backwards, and you're going to check their pedal pulses as well as their feet very carefully. For your diabetics, this is a very important step because things like neuropathy can cause damage to the feet that they are not aware of. And you might want to do education as far as that is concerned here. As you continue, you're going to check to see, are their nails well groomed? Are the feet warm? Are they cold? What does the skin look like? And you're going to want to ask them to push down as if they're on a gas pedal and pull back up as well to check the strength. This is one of those areas where if they have to use the restroom or change positions to get in another chair, this is a great opportunity to see them do that, to also assess their gait and strength. And this concludes the head-to-toe assessment. As you continue on with nursing school and in your nursing profession, you may add or subtract to your head-to-toe assessment as necessary for where you work and who your patients are. Good luck!